any of you who know me at all will know what a technophobe I am, and that having to use this will stretch my computer abilities to their absolute limits, but we'll see how it all goes. I'm Neil Wright. I'm the consultant psychiatrist for CDAT, have been for the last 18 months, and I'm going to try and fit into the next 30 minutes as much as I can with regard to what CDAT are up to at the moment and what we hope to be doing in the near future. 30 minutes isn't a lot given how much we're doing, and I want to put emphasis really on our work to try and reduce the overall level of opioid substitute prescribing within our service, and what we can do to limit the general availability of illicit opioids. So this is the content, and it's going to be a whistle-stop tour really of who we are and what we do, and then a little bit more time devoted to the sort of quirkiness of the Guernsey drug scene and what that means for how CDAT have to work. And then a good bit of time on the statistics, our prescribing statistics, because there's some interesting trends there, and if there is time, a little bit of focus on future developments. So just a very quick bit about me. I've been here for 18 months. I worked in drug and alcohol services as consultant across various parts of England for many years. I think the one comment that I'll say, given the time that I've got, in all of the time I worked as a consultant for drug and alcohol services in the UK, never did I really imagine what it would be like to run a drug service where there is no consistent availability of heroin on the streets. I'm absolutely used to providing drug treatment for people who take heroin, and here it's rarely available, and that really does change how services have to provide for people with drug-related problems. So a very quick look through who is in CDAT. We're a multidisciplinary team, a relatively small team, but we have grown over the years. Referrals into CDAT, we're a very accessible service, lots of different referral routes. You'll notice that self-referral isn't on there. Essentially, people can self-refer to us via independents. I'll just mention independents for a little bit because they are the other drug and alcohol service on the island. And between independents and ourselves, we provide across the spectrum of drug and alcohol related problems. You might know that independents as Drug Concern. They recently changed their name to independents. They were known as Drug Concern for decades. So if you think of CDAT as providing for the more severe, the more entrenched, the more difficult to treat clients with drug and alcohol related problems, and independents treating people who have got lesser problems, you'll have got an idea of how we divide things up. But I'll say some more about our eligibility criteria in a bit. Indeed, I'll say it now. Yes, I'm giving away how much I've prepared here, aren't I? Shock horror. The eligibility criteria for people with drink problems being taken on by CDAT are relatively high. And essentially those three criteria there amount to those which would make medicated detoxification a possible part of a treatment package. But I must emphasise that because we work with people to try and get them to take responsibility for their drinking and to change it themselves, many people do cut down to the extent that they no longer experience alcohol withdrawal, and therefore medicated detoxification becomes an irrelevance. And so those people end up with a treatment episode with us which doesn't include a medicated detoxification. Of those who do receive medicated detoxifications, the vast majority are treated in the community. We very rarely resort to using inpatient beds. you'll see that there's other special groups of people, particularly pregnant women and people with significant mental health issues, who will accept with lower levels of alcohol-related problems. And then there's another specific group of people who really are perhaps the most troubled by their drinking, people for whom their drink-related issues involve considerable physical deterioration in particular, but often also a rather transient lifestyle and generally a completely drink-orientated existence. And for these people, it may not be that they have the capability of attaining abstinence, even if we detoxify them. But for having them in our service, and particularly during a period of detoxification, we might be able to provide them with interventions for their wider physical, psychological and social needs. And therefore, we're treating on the basis of harm reduction. Eligibility criteria for drug takers. Well, this is essentially the eligibility for access to what we'd call opioid substitute therapy. And that essentially means us providing, or prescribing I should say, an opioid to somebody who's already taking an opiate or an opioid illicitly, so they get a legitimate prescription medication, rather than trying to find what they can from the streets. It's a long story why drug services focus so much on opioids and not on other drugs, and that would just take too much for this short presentation. Suffice it to say that independents will see people with opioid problems as well, but lesser problems than us, and they will mostly see people who have problems with other types of drugs. I should emphasise, though, that almost all of the people who we see with severe opioid-related problems are taking other drugs anyway, and that is not ignored. I simply haven't got time to go through the treatment interventions that we have in the time that's available, because I do want to set aside plenty of time for the statistics. But suffice it to say that we provide a lot of psychotherapeutic interventions and pharmacological interventions. Right, so the peculiarities of the Guernsey opioid drug scene. And this is where I want to spend a little bit more time. Only very intermittent availability of heroin. So what is available on the streets is actually pharmaceuticals, mostly. So nearly all of the opiates or opioids taken on Guernsey are pharmaceuticals. So in stark contrast, as I've already said, to almost anywhere else, certainly including the UK, where heroin dominates the whole scene. Well, this means that the pharmaceuticals here have a very high street value, which they don't really in the UK. And that means that diversion of them, I'll use the word diversion, I might fall into using the word leakage, I mean much the same in the two terms. Diversion of prescribed opiates and opioids is rife on Guernsey, as is diversion of other prescribed drugs that people can get reward from. So there I'm talking about tranquilizers, benzodiazepine tranquilizers, non-benzodiazepine tranquilizers, and gabapentinoids particularly. So the next thing to say about the peculiarities of the drug scene on Guernsey is that drug dealing on Guernsey is a rather simple sort of process. It's individuals selling their prescription medication to another individual, and another individual there selling it to another individual. It's in stark contrast to the UK, where there are complicated routes of heroin getting into the country. There's then complicated distribution through drug gangs. There's hierarchies within the drug gangs. The gangs have their own territories. They deal to a large number of people. There's competition between each gang and a lot of violence and criminality, and indeed considerable links to wider different types of criminality. utterly different to Guernsey, where somebody sells their prescription Coco de Mol to somebody else, or their prescription MST to somebody else. Opioid users on Guernsey have relatively high levels of personal resources and non-drug involved social supports, I've put there. Essentially what I'm saying there is that a lot of people we see are relatively mainstream, as it were, which is again in stark contrast to the UK, where heroin users are often very marginalised, disenchanted individuals with little hope of any employment, often alienated from all family and friends, etc. Leading a life which is utterly drug dominated, in so much as what they do on a day-to-day basis is steal a lot of things, sell them on, then use the money to buy drugs, so they have to find their dealer, buy the drugs, then they take the drugs, and then they just repeat the whole process. And in all of this time, they vary between being in a state of some level of intoxication or in some level of withdrawal. Their social network is with other drug takers who are similarly marginalised. So all that they do, and everybody who they meet, just reminds them of drugs. I'm a drug taker, what else could I be, what else could I do? Their identity is very strongly as a drug taker. Not at all like that here. People identify as being, a parent or a worker in some profession or other, or some capacity or other, I should say. And often have all sorts of other activities and interests which form part of their identity. So the upshot of all of this is that there really isn't a cohesive drug subculture within Guernsey in the way that there is elsewhere, and that the levels of opioid problems in Guernsey are relatively low compared to elsewhere. So how do these peculiarities impact on how we provide opioid substitute therapy? Well, first it's obvious, but it's the way it is. The drugs that we prescribe as opioid substitutes aren't true substitutes. They are the drugs that are being leaked and are available on the streets. So we have an odd sort of situation in which people come along taking pharmaceuticals and get so-called substitute pharmaceuticals. So what they get is very similar or the same as what they were having on the street. And there's a danger here, of course, that the person comes along and says, well, thank you very much, that'll do very nicely. I've now got my drug of choice from you, free of charge. What else is there to say? I'm sailing pretty close to the wind in terms of being their drug dealer, really. That's in stark contrast to what I would see as proper and traditional opioid substitute therapy, where the person comes along and has to make a compromise, essentially. They come along having a heroin habit and are offered usually methadone or buprenorphine, neither of which are anywhere near as rewarding. And therefore they say, well, all right, reluctantly I will take this, but what do I get in return? And you say, well, what you get in return is drug counselling and a whole lot of advice and support in all areas of your life, etc., etc. You get drug treatment. And there's the dynamic that exists which allows for proper drug treatment. So there's a big difference there between what can happen here unless we're very careful in how we do drug treatment and how it works in most places where there is availability of heroin. Because diversion of pharmaceuticals feeds the drug scene here, supervised consumption should be used very commonly. And by supervised consumption, I generally mean supervision at a pharmacy. Clearly, the more supervised consumption we have, the less leakage there is. The less leakage there is, the less there are people having availability of opioids on the streets, and therefore the less people are coming back to treatment. Also, because people with opioid habits here tend to have quite a lot of personal resources and social structures and low levels of drug-related problems, as I've already said, they have what would be seen as recovery capital, which is the trendy way of putting it. Essentially, it means that they should have the wherewithal to do well in treatment and to move on. Okay, so what is CDAT doing to reduce diversion of prescribed opioid medication? Well, the first 2 points here relate to duration of treatment. Clearly, if the duration of treatment is shorter, then the cumulative amount of medication that I'm prescribing is less, and overall the amount of leakage will be less. The third point relates to trying to avoid escalation of doses, and again it's obvious that if escalation is avoided, then diversion is liable to be less. The fourth and fifth points relate to supervision. I've put unsupervised dihydrocodone and phasing that out. I might have put unsupervised and unlicensed dihydrocodone because it's not actually even licensed for use in the addictions field. But phasing out unsupervisable dihydrocodone and also increasing the general levels of pharmacy supervision clearly will help to reduce diversion. And these are two things that we're doing. Incidentally, you might wonder why dihydrocodone is essentially unsupervisable. It's because it's a relatively short half-life medication, and even in its longer half-life form, it's still twice daily taken, and therefore you can't really have people going to a pharmacy twice a day to be supervised, and it'd be prohibitive at a cost level as well. And finally, we've got Buvidal here, which is a new preparation of buprenorphine, which is a depot, and clearly being provided as a depot takes away the potential for diversion almost completely. Well, I can take out the almost, can't I? I mean, how could you divert it at all? Yes. Yes. We're on to the graphs. I knew they came soon. Now there's an interesting little picture, and I'll explain it. So what we've got here is total number of people on opioid substitute therapy with CDAT against time from the early 90s to the current day. And whilst the figures of 170 and 144 that you can see are quite recent figures, the rest of the curve has been created as best I can on looking back at old records and getting figures as best I can. The stats don't really exist, but that is pretty accurate. And it's an odd shape. And it's an odd shape for the following reasons. In the 90s, what was to become CDAT was really just one or two community nurses who were mostly focused on alcohol detoxification. So there was little availability of opioid substitute therapy, and hence numbers were very small. It's also the case that in the 90s there was something that looked a bit like opioid substitute therapy, which was going on in primary care. And so people with drug-related problems were drawn to some GPs who were prescribing opioids, were prepared to prescribe opioids to them. Most unfortunately, that was not being done very well, and there were some drug-related deaths. And in 1998, methadone prescribing was withdrawn, and GPs were dissuaded from prescribing any other opioids to people with clearly had opioid-related problems. So this changed the dynamic of things, and CDAT expanded to take up the demand, and you can see that the demand took off quite remarkably. The demand, as I've already alluded to, being understandable in part because of the now better availability of services. So there's a higher penetration into the drug-using population, but also for providing the services and having them very accessible, and the prescribing being done in a fairly upfront, accessible way, there was more leakage, there was more diversion, which then fed demand. Now, this demand was also still coming from general practice and other sources, but these were people who were presenting ostensibly with pain issues, for instance, and then getting overprescribed, and then seeking out additional street supplies, etc. So there are multiple factors here at work in terms of the understanding of the almost exponential rise in the number of people on opioid substitute therapy. But we've turned a corner, it seems. It seems that the changes in treatment philosophy, the changes in prescribing practice have caused a very decisive change in the trend. So here you can see on the top line is the total numbers, and you can see where we hit our peak of 170, and you can see where we are now at 144. And what we have below there is the buprenorphine prescribing, and then at the bottom one is the dihydrocodone prescribing. So we've got total numbers on one axis, and then we've got the last 18 months on the bottom axis here. I've already explained why we need to eliminate dihydrocodone prescribing. It is a quirky thing about prescribing in Guernsey. It's not used elsewhere in addiction services, and I've already said that it's not even licensed for doing so. We've had considerable success in reducing the numbers, as you can see, down from 69 to just 27. Not surprisingly, some of that success has been achieved by swapping people over to buprenorphine, and hence the total number of people on buprenorphine-based medication has risen. But the overall numbers, as I've already pointed out, have dropped. It's looking as though the reduction is bottoming out, as though the measures I've taken have produced an effect which has now reached its end. And it might be that we need to take further measures if we're going to expect any further falls in the total number of people on opioid substitute therapy. But perhaps it's early days yet, and it might fall some more. So, average dose of dihydrocodone, remember this is unlicensed, unsupervisable. So the axes here are milligrams per day, and again it's the last 18 months. And again you can see a very considerable downward trend. To put these numbers in perspective, I'd point out to you that the maximum prescribable dose of dihydrocodone per day for pain control is 240 milligrams. We have an average 18 months ago of 880. That's an average. So although we've reduced to 507, it's still shockingly high, but that's a large reduction. So I've shown you a reduction in total numbers of dihydrocodone prescriptions from 69 people to 27 people, and of those 27, the average dose has reduced greatly. That means that the total amount of dihydrocodone that we're prescribing, which obviously is a product of both the total numbers of people and the average dose, has come down to less than a quarter of what we were prescribing 18 months ago. That's a considerable success. This is not such an interesting chart, because this is our average dose of buprenorphine. I'd have to say the average dose of buprenorphine at the start of the 18 months was within what you would consider therapeutic and justifiable, and it's fallen just a little bit. Now, if you've got a cohort of people who have shown themselves to have a huge appetite for opiates, you wouldn't be surprised that they have a large appetite for other central nervous system depressants, chief among them being benzodiazepines. So for treating this group of individuals, you get with it benzodiazepine issues. People who are already on prescribed benzodiazepines, people who are taking illicit benzodiazepines, people who are doing both. You've got here, again, total amount of diazepam or diazepam equivalent plotted against time over the last 18 months. And our general philosophy of treatment and how that has changed has produced about a 32% reduction in total benzodiazepine prescribing, which again is a very marked reduction. I've been banging on about supervised consumption as being extremely important here in Guernsey. 18 months ago, we had just 10% of people who were on opioid substitute therapy on supervised consumption at a pharmacy. That is astonishingly low, very inappropriately low. We've now risen to 37%, which is still too low. It now does also include people who are on Buvidal, these figures. So simply it's all those people who are either supervised or on Buvidal, i.e. ostensibly not in a position to divert their medication. So we've come a long way there as well. I'm conscious of the time. Future developments, well, we have ambition to expand our opioid substitute therapy menu, as it were. I'll especially mention Espranor. Espranor is a freeze-dried wafer version of buprenorphine, and it dissolves extremely quickly, very much quicker than any of the other preparations that we have available at the moment. Now, because I have taken measures to reduce the leakage of opioids, including buprenorphine, onto the streets, the price has gone sky high, and people will now spend good money on buprenorphine that's already been in somebody else's mouth. So people who are under supervision are finding ways of trying to divert their buprenorphine and being paid for something which is still intact enough to fetch a price. With Espranor, it dissolves so quickly that's really not possible. The reintroduction of methadone is imminent, and that could be a talk in its own right. We want to have closer links with other medical services. We have ambition to do better at helping people with benzodiazepine issues. I think it's inevitable that we will take self-referrals in the foreseeable future, although, as I've already said, there's very easy access and it's almost like a self-referral via Independence. If somebody just wants to be seen by us, they go to Independence and get a referral on, and in that way they don't have to pay a GP to do it. And we want to promote and expand our alcohol treatment and certainly get to a position where we're able to lower the threshold for acceptance of people with alcohol problems into our service. That's been a bit of a rush. I've almost done it on time, and I hope it was interesting.
Improving dementia care in the acute hospital setting. This basically means what we've done on Brock and what we think we all should be doing. Ooh. So, there you go. What I did was, first of all, I looked at worldwide statistics. So this is all really brief. And all these statistics came from the websites that I looked at back pre-COVID when we were going to do it. So if any of these are wrong, then that's why this is just from January, February time. So approximately 50 million people have a diagnosis of dementia. So this is from World Health Organization, September last year. Every year there may be more than 10 million new cases. So remember, this is worldwide. An estimated 82 million people with dementia by 2030, and it's actually 152 million by 2050. Alzheimer's disease is the most common form of dementia, and 1 in 9 people 65 years and older will be diagnosed. And that bit shouldn't be on there, sorry. I do apologise. And then I looked at the UK. So this is from dementiastatistics.org. So there's all those people living with dementia. That's from May last year. And 57% increase in diagnosis between 2010, 2011 and 2015, 2016, so that's a really big increase. Sorry, that next one's meant to be on the next slide. I looked at Guernsey as well, and on the Dementia Action Alliance data for this year, in Guernsey, approximately 1,200 people diagnosed with dementia. So then I've looked at Brock ward admissions over just 1 month, so this is really, really simple. So this is patients with dementia that are coming into an acute medical ward with an acute medical condition, whatever that may be, or coming in as a social admission. So over a month there was 4 males and 16 females, and out of those 20 patients, 1 had Korsakoff's, 3 had vascular dementia, 1 had Alzheimer's, and 15 had dementia. That was basically what the diagnosis was, dementia. There wasn't any other specified type. So I had a look at some research, and the National Institute for Health Research in June 2019 studied patients admitted with dementia to an acute hospital setting over 10 wards throughout several UK trusts, and the findings included a lot of the patients resisted or refused care. Staff assumed their behaviour is always due to dementia and didn't look into delirium or pain, infection, constipation. Negative staff responses towards the individual, lack of ward flexibility, and that meant about where they put their patients, and lack of essential skills, specialised training and knowledge, and that obviously is to do with staffing. Mercy University in Cork, an occupational therapist did a study and then prepared a guideline on how to create a dementia-friendly environment within the acute hospital setting. So clear signage, she suggested clear signage, declutter, trying to reduce the amount of noise, so stopping overstimulation, making the lighting a bit dimmer, having pictures around, making the flooring less confusing, so making sure there's specific colourings between the floor and the walls, orientation through colour and pictures, and communal spaces. So John's campaign is something that when we reopened Brock, we spoke about bringing onto the ward. However, we haven't formally done it, but we always have done it without telling anybody. So any patient who is poorly, any patient with any cognitive disability, but especially with dementia, we allow their family, friends, carers in. The carers become more involved in hospital care and treatment of their loved ones, and both the carer and the patient feel more relaxed and less frustrated. Ooh. The butterfly scheme is a lovely idea, which I actually spoke to Gary Whitwam about, again pre-COVID. It's a national scheme that in the UK, which the whole hospital has to sign up for. You can't just do it on a ward basis. And what it is they provide training and online support for staff. For staff. And they also provide appropriate training to help staff and carers with communication. The patient and carer has to opt into the scheme, and they provide them with a carer sheet, and this provides staff with information about how to deal with the patient's challenging behaviour and how best to support and help. Can somebody move a bum cheek or something just so we can hear the beeping going on? Keep going. Stand up. So yeah, so sorry. You sign up for the butterfly scheme, and then a butterfly symbol is placed in a visible area around the patient's bed area or space, so everybody knows that that patient has dementia, and that there is an easy to use information sheet to know what to do. So closer to home basically means what are we doing on Brock and why are we doing it. Why are we doing it is because of SCAPE, basically, the audit standard 15, because we've all got to do better. I'm quite passionate about this subject, and I know we all do need to do better, and our attitudes need to change. So we sorted out clear signage for the ward, and then we shared it with Carey ward, so that's toilet signs and shower and bathroom signs, and that's after looking on the dementia websites, so you can make sure that you have the right colour on the right background. Up there's an album with old Guernsey photos in that we use quite a lot with a lot of the dementia patients, and that instigates conversation with us and with their families. There's those photos we also put into a collage, a double-sided collage that we stick on the wall in each of the rooms. Wellbeing nurses. When we were on Brock, before we moved to Carey to become Brock, we had wellbeing nurses. I think that might just be me, but plus everybody else really, because everybody should be a wellbeing nurses for all of our patients. The sensor mats. Perfect. Haven't gone off much, but I've put there annoying to patients, increased falls risk, and sit down. The annoying to patients is, to be honest, they're brilliant for us because obviously they alert us to the fact that somebody's standing up and will become a falls risk, and that's why they've got a bed or chair sensor. However, they go on and on and on, and a lot of the patients will stand up and try and switch it off. So it's really hard to weigh up the benefit. And sit down is just a bugbear of hearing staff sometimes saying to a patient, sit down, sit down, sit down, sit down, rather than doing something with them or taking them for a walk. Because most of the time that's what our patients want to do, is just go for a walk. So what was meant to happen with the sensor mats were, you were all meant to move, and then they were meant to go off and be really annoying, but it's not worked like that, so that's... Individual staff allocated to walking with the individuals. Again, that's what we did on Brock before we moved to Carey and became Brock. So, but at the minute it's, you know, if somebody needs to go for a walk, then a member of staff needs to do it, whoever they are. Opening visiting for any patients with cognitive impairment or who have carers, we've said that. So we've got specific activities for patients with dementia. I've bought an Active Mind jigsaw, there's a game there. We've got a big box on Brock with lots of Active Mind jigsaws, which I just got off Amazon because they're specifically for patients with dementia. There's games, we've got mindfulness, colouring books, as well as ones for patients with cognitive impairment. We've got crosswords, we've got chess, we've got drafts, we've got card games. The Rita is what we're going to talk about, the three of us, in a minute. And Le Marchant hold frequent tea parties in their day room. which everybody is invited to. So I've just put here the challenges to delivering dementia-friendly environments in the acute hospital setting. So using Bay 3 for activities was when we were on Brock before we moved to Carey, and now Bay 3 is COVID if we have COVID. So that's out because we might end up with patients in there. The layout of the ward means that patients with dementia are always seen as a high risk of falls. So I put this in purely because the minute we hear somebody's confused or has dementia, we put them in a high observation room because we see them as a high risk of falls. So then we put a bed sensor or a chair sensor, and then they're in a very overstimulated room because of the phones going off and everything else, so we make things 20 times worse. But what else do we do? It's very difficult. So I've inappropriate setting for medically fit patients. So these are patients that are maybe waiting to go to a residential or a nursing home, waiting to go to NAP, waiting for a social work allocation, waiting for a package of care because they've been waiting for 3 weeks for that package of care, and it's really, really difficult. And it's frustrating for nursing staff because we see that we can't give what we should be giving. Acutely unwell patients versus individuals at risk of falls, that is literally your patient with chest pain, your patient who's bleeding, versus the patient that's just stood up, Brian, who's just stood up, and there's maybe only me because everybody else is busy. Yeah, that says it all really. And staff attitudes is the sit down and the busyness. Yeah. So the way forward is basically, I've put these things: training for staff, and that should include communication skills about how to speak to a patient with cognitive impairment. And of course now the dementia training is online, isn't it? Improved communication between resi and nursing homes on admission. We do get transfer letters, but not very often, or we have to phone up 3 days later for them, so that needs to improve. And also the hospital hospital passport isn't, in my experience, isn't used as it should be. The greater partnership working with older adult mental health teams, and more staff to ensure person-centred care. So that's basically, it's more staff and more time that we need. And on a lasting thing, I think, is it? No, not yet. Yes, not yet. I put that about more staff and person-centred care because we've had a patient for a while who's been one-to-one, and it's been absolutely fantastic seeing the guys watching football with him on the iPad or playing drafts with him and the different games that we've had, and it works, but that only works because those guys are there on overtime because of the situation. So it's money and time. It always comes down to, doesn't it? I've put dementia linked nurses. There doesn't seem to be any of them, so we need some of them. That would be quite good. Quiet areas. It would be lovely to have a quiet area. And in a perfect world, we could redecorate the rooms and update the bedding so it's calmer and more recognisable to the patients with dementia or cognitive disabilities. And an activities room and activities coordinator. And I also put volunteers as well would be quite nice. That'd be lovely. Reader and the iPads. And then this is really the last thing, is liaising with all departments, especially ED, prior to admission to the acute wards, so they can maybe borrow Rita, but that's the next bit. And that's it. Sorry.
So, but basically, on the back of what the work Joe had done, and actually to be fair, Kerry Ward as well took up John's campaign. They were asked to take up John's campaign formally by Elaine, so they did a lot of work on that. But on the back of what Joe was saying, the simple fact was that because of all the issues we had with dementia patients in respect of we feel we weren't definitely not meeting their needs, and on many occasions we kindly asked I and actually the elderly mental health team, Ellen, and people such was to come across and help us if we had anybody admitted from there to try and see how we could try to make the journey for those patients better. So as a consequence of that, we looked at things like iPads, how we could try to get something, anything that would help us to engage the patients as best we could, because staffing is always going to be an issue. That's, you know, as much as we try. And so we raised some money for iPads, and we had some good donations, and they did quite a lot of fundraising on Kerry and the Merchant and ourselves with different things to get some money together. But then we were going forward with the iPad situation, and then Debbie had gone off to Gloucester. Debbie can't be here today, Debbie from Kerry Ward. And she'd gone to Gloucester to the Royal Infirmary there as part of a trip that was set up by Elaine. And she came across this RITA, which is, and I get it right, the Reminiscence Interactive Therapy Activities, which is an actual computer program, which is actually designed for patients with dementia. And it's actually exceptional. I had never seen it at all, but Debbie and I had spoken with Ollie and obviously Joe and the staff from the wards and decided that we would plough all the money in together and go for the bursary, because these actual computer programs were quite expensive, so that's what we did, and we actually won the bursary for Rita. And so as a consequence we have ended up with a large Rita, which is a large screen of computer activities, which Ollie will tell you about, and two small ones. The large one sits on the Merchant ward because it's the best area for it to be. It's a lovely big day room and they've got all the facilities there, and the two small ones sit on Brock and Kerry. But I say sit because of COVID, they've never gone any further at this current time, because they were meant to be up and running in March and it never happened. So that's at the minute where they sit. But that's, I'll pass you over to Ollie or Joe for that. Actually, I've left Joe to do this. So the benefits for the server users, Ollie will tell you about.
Hi, good afternoon. My name's Olwood and I'm the sister on the Merchant ward. I'm sure you'll know some people.
Move in a bit because you're not answering.
Oh really? I should understand you. And I'm the sister on the Merchant ward and have been for the last 20 plus years. Anyway, we're moving forward quite significantly in the last few years and working again with the medicals. We're all part of the medical unit anyway. And looking at what we've just been talking about and what Joe's done a lot of work on as well, and we're looking to bring that forward on the Merchant ward, which I'll talk about in a minute. So basically, we have got the large screen on a table, and it's at the moment dormant, and we will in the future look for some training and how to use it and how to work with it. So it's a large screen, and it's on wheels, so we can move it around the ward if so we need it. And as I say, the benefits would be for any patient to distract them, or whatever words you want to use. We've got two stations on the ward, we could bring it onto there. And if you wanted a quiet area, we have an actual quiet room, which is just a library area, but it's a quiet room that you could take the patient off the ward. They could go in there as well. And it also looks at, with the activities it has on it, which I've asked, could assist with the sleep and awake cycle as well.
So,
and again, families can be brought into this because we always look at holistic care and rehabilitation as we do on the medical wards as well. So families can be involved in this and work with them. And there's, as it's used as a Skype facility, so families can't get in. Unfortunately, if it was up and running before COVID, we could have used it much more effectively through COVID, but unfortunately we couldn't. And also looking at patient-centred care with this as well, person-centred care.
So what Rita does, it's actually a program. So it's actually a program that you can put in your own information to. It's data protected the way it works. it's, for instance, if you wanted to sort of, if you wanted to put down it, so you'd set up your programme for each patient. So for instance, you would look at it and you'd say, right, there's Joe and there's John or Joe, and he lived through the First World War, and that's a lot of his memories, and you could put all the things in that he would enjoy, or he enjoys football or cricket, and he would have his own personal programme that would make him perhaps have some reminiscent practicalities that would make him, trigger him into being interactive with it. It uses it for games, things like that. Families can interact with it, and that's its sort of basis. It sounds very basic because it's a very quick sort of introduction to it. But we purchased the Rita tablets, and the thing was to get the information out to the wider audience. Our initial thing was that we were going to make this hospital-wide. So our initial thing is that we were going to start with the medical wards. They would use it, as Joe said, in ED. You'd use it when a patient came in. We'd try and link it out to the elderly mental health wards as well. And it would be something that it would be hospital-wide, even looking at going further to even Aldern, sort of taking it across the bailiwick. That was our actual idea, because once you get going on it, it's actually really very good if you could see it in practice, which unfortunately we can't at the moment. And it's too expensive to bring one down. Yeah, that's the point. And it's not set up properly, so you wouldn't have the benefit of it. And also, we needed to get staff training on it. And we were continuing to fundraise, and we were doing really well, because the whole thing came to about £13,000 just for those 3 monitors. And we'd actually done that, and we've still got much more money in the pot. So that was the idea, to keep fundraising and actually make it throughout the hospital. However, it kind of all went to a little bit of a setback because of COVID, which was very unfortunate. Really. Yeah. So I think.
So this was a part of our presentation for the bursary, that we had to show what the measurement of success was for Rita. So what we've done is we have printed out a couple of the articles which is feedback from patients and service users from the trusts that have actually used Rita in the UK. So they are over there. So the measurement of success is the positive feedback from patients. There is reduction in falls because it occupies the patient and it focuses them and provides distraction, and a reduction in patient service user anxiety and behaviours that may challenge the service delivery. So it's calming, relaxing, and may improve the sleep-wake cycle as well.
Also did a reduction in the hospital stays. So the evidence that they've had up to now in the hospitals that have initiated this in the trust is that it actually reduces hospital stay, and it does ensure an individualised person-centred approach to care, because it's about that individual. It's not just like this patient has dementia or has some form of dementia, and therefore it's just we're giving them all the same thing. It's a very personal thing that their relatives and them can feed into and have some sort of ownership of as well. So that is the basis of why they feel, or the research showed that it had a much more individualised person-centred approach to care. And it did foster collaborative working. For instance, if a patient came across from you, Di, on your wards, and they were brought into the medical ward, you could actually say, well, this is a part of the programme. If you had, this is what they need, this is what they like. So it made it much better, and that's what it should be about. It shouldn't be sort of one thing for one person, especially with dementia patients. Because we found the most simplest thing is when I think you came across and you said, take them away from the noise, put them here, and the whole patient changed completely. And so it's really important that we engage with that, with collaborative working. So.
As before, Moira, thank you, Moira, I said that the funding will continue to be raised to get more iPads and to look at training and moving forward with this. And it's excellent. Can I just sell my ward for a little minute? The Marchant is a rehab ward. We've been working a lot, as I say, with dementia patients. We have now, you were talking about people coming into our ward and things. There is a thin line here because you can have people visiting and things, but also I always say, Di, there's a very thin line of patronising. I'm always very conscious of that. With dementia care, well, with all patients really. So we have, on our ward, we have the dog visiting on a Tuesday, we have a coffee morning on a Thursday, we have, through the Arts Commission, through Lottie Barnes, we have a storyteller called, his name's Ollie, and he comes to the coffee morning. And he did ask me a question, he says, what do you want me to talk about? And I said, well, first of all, ask the patients and see what they would like to talk about. But also, don't always talk about the war. People don't always want to talk about the war because it brings back not good memories, sometimes bad memories. So talk about their holidays or something like that. You know, it's just gauging the patient really at the time. So we have that. Once a month we do an afternoon tea where we bring families and patients together, and I'm sure some nurses have been here at the afternoon tea and helped. And it's been really good, and some patients are brought down to the medical unit as well, which is really good. And we've sort of got a dining area. We're trying to we encourage patients and families to go through and make a cup of tea, get the patient to make a cup of tea. It's all part of rehab. We also have a gardening club as well, where the physiotherapists work closely with us as well to create this gardening for mostly the stroke patients for movement as well. And at the end of this month we've got afternoon tea one day, and the following day we've got a pony coming onto the ward. So anyone who's got children, they're more than welcome to come to the ward, and the last Friday of this month there's a pony coming. So I work closely with Linda Lavasser as well. She does all the entertainment for the afternoon tea once a month as well. And we're getting the other part of our dining room is getting painted soon, and we've raised some funding for medical fireplace. I think you have one up in the other wards, so we've got some funding enough for that as well, just to create something, a homely atmosphere, but enough that you can bring your patients and families through and make a cup of tea and have a more social environment and bring people together. You're always welcome to come to our afternoon teas, as I say, once a month, but you're all welcome to come down and have a look through the ward and see what we do and what we're proposing to carry on doing. Thank you very much.
Thanks, Ollie. So, I know, Ollie, you sold it to me, Well, I was just going to say one thing, sorry. So, going back to Rita, because it is very limiting our explanation of Rita, because obviously we were preempted a bit more for the presentation, but it would be very good if once we do get which Debbie had tried to sort out the education for about a month ago, but there was a problem with networking, the actual network itself. And if we actually get some people down from the elderly mental health wards, that we can show them, because it might be something that you guys would want to actually be able to come down to Ollie's ward. That's why we've put the big screen on Ollie's ward, and it might be something we could try to work together with. Because I think the collaboration work is so important. Really.
Just one thing I forgot to say, that we've got an activities coordinator. She's coming to the ward at 15 hours a week, and we'll build on that. We can share with the medical ward as well. If we've got patients, she can go up there or come down, and she will be part of this using the Rita as well, along with their patients. So another success. So that's really good for the whole medical unit.